So good morning, everyone. I'm really excited to be here, and I want to thank Dr. Jurkovec for inviting me. It wasn't a very long drive, so it was actually quite nice coming up this morning. So as you see my title, I'm sure, and we've kind of already set the stage. Should I use this or this? Oh. In case I want to walk. Okay. So we've kind of already set the stage for thinking a bit about disparities in kidney disease, which is going to kind of be the topic of our time together, hopefully over the next 30 or 35 minutes or so. And what I'd like to do with you is to kind of begin our time together in a similar way that I'll end, and that's to say that disparities in kidney disease are pervasive, but they may be surmountable. And so before we get into the objectives of our time together, I wanted to mention what was said earlier, that is that I do some consulting for the MITRE Corporation, but there is no relationship between that work and what I'll be covering today with you. And so our objectives are going to be to first sort of describe what's meant by disparities. I think it's important to make sure that we're all talking about the same thing when we think about disparities. And then we'll go into some of the key disparities in chronic kidney disease. Then we'll look into thinking about some of the potential root causes of these disparities. And then next we'll talk some about how these disparities might actually be able to be reduced or mitigated. And then finally we'll think a bit about what clinicians and health systems might do to address disparities in chronic kidney disease. We won't cover this very much, but I hope it will sort of spawn the discussions that we'll continue to have over the course of the day today. So first, again, I make no assumptions about whether some of you in the room may be experts on this topic, but I want to make sure we're all talking about the same thing when we speak of disparities. So a disparity is defined as a difference or a lack of equality. When we speak about health disparities, these are population-specific differences in the presence of disease, health outcomes, or access to health care. Now, the Institute of Medicine put forward a report some years ago that stated that health care should be safe, effective, patient-centered, timely, and efficient, and that above all these things, health care should be equitable, meaning that care should be provided that does not vary in quality because of personal characteristics such as gender, ethnicity, the geographic location of where a patient lives, or socioeconomic status, so things like income or educational level. And then if we don't have these things, what we have are health disparities. And so when we think about disadvantaged populations in terms of how they relate to health and healthcare disparities, these are going to be groups that are adversely affected individuals who have systematically experienced greater obstacles to health that are based on a number of different potential factors, like the ones that are listed here, including racial or ethnic group, religion, socioeconomic status, gender, mental health status, sexual orientation, geographic location, or any other characteristics that historically have been linked to discrimination or exclusion. And so in chronic kidney disease, there are a number of disadvantaged populations. Now, during our time this morning, we'll focus on racial and ethnic groups, and we'll also focus on SES, which is socioeconomic status. But there are a number of disparities or disadvantaged populations in chronic kidney disease that have been documented in the literature, including around gender, and I'll just note a few of them. So overweight or obese women are actually less likely to receive transplants than men. And so when Dr. Swanson was speaking about that men they're overrepresented in the transplant population, it's in part due to the fact that men are indeed overrepresented in the ESRD population, but there also appears to be some disparities in that access and receipt of transplantation is greater for men. With regard to mental health, major depressive symptoms have been associated with increased risk of developing end-stage renal disease among people with diabetes. And then regarding geographic location, people who live in more remote areas, like rural areas, are less likely to receive specialist care, such as seeing a nephrologist. They're also less likely to undergo some of the laboratory testing we talked about earlier, like the urine albumin testing. And they're less likely to receive some of the medications that are recommended for chronic kidney disease patients, such as the certain blood pressure medicines like the ACE inhibitors or angiotensin receptor blockers. And these individuals living in remote areas are also more likely to die than those who live closer to a nephrologist. And so this, earlier this morning, the social determinants of health were mentioned. And just conceptually, what we think about when we're thinking about the social determinants of health is that kind of at the bottom there, we have these sort of downstream effects. We have the we take, just as an individual, we're going to be of a certain age. We're going to be either male or female. We're going to have other constitutional factors like our genetic background that kind of make up these individual aspects. And then upstream from that, we have lifestyle factors, what we eat, whether we exercise, that play a role in our health. Upstream from that, we have our social and community networks that play a role. And then further upstream, we have our living and working conditions. So whether we work in an environment where we're getting some toxic exposures, or whether we have clean water, whether we have access to healthcare services, and whether we have adequate housing. And so these are considered the social determinants of health. And so thinking about that, let's turn to some, I just want to highlight a few of the disparities that have been documented across the spectrum of chronic kidney disease. And what I'll start with are disparities in pre-end-stage renal disease, chronic kidney disease. So Dr. Shahinian kind of spoke to you about how we characterize end-stage renal disease, and then the earlier disease we often will think about as CKD. So it's been said today, we've spoken a lot today about diabetes and hypertension, and it was mentioned that probably many of you know that rates of diabetes and hypertension are certainly higher among several racial and ethnic groups in the United States. That's not, everyone sort of knew that, right? And so given that, one might think that then that might explain the higher rates of kidney disease that we see, right? Would that make sense? That we see among racial and ethnic minorities, right? So this study was one of the earliest studies to really kind of debunk that notion. And what it essentially is showing, and I apologize that I am an epidemiologist, so I will be showing a lot of kind of data-heavy type of slides. And for those of you that are less familiar with this type of thing, I will try to make sure I explain the slides. But in this figure, this is national data in the U.S. And what they did was they divided up the population. They were looking at blacks, Mexican Americans, and they looked at those participants in the study who either didn't have diabetes or either did have diabetes or did not have diabetes. And the big message is that the rates of albuminuria, so this is this protein in the urine, the rates were actually higher for blacks than they were for whites, and they were higher for Mexican Americans than they were for whites, regardless of whether those individuals had diabetes or not. Okay, so it's not, this disparity in rates of albuminuria is not explained by the greater rate of diabetes among these populations. That's sort of the key message. And so one of the things that I've been very interested in my work is in looking at poverty as well as looking at income level and seeing how it relates to the presence of kidney disease or risk of kidney disease. So here again, we're looking at albuminuria, again, this protein loss in the urine. And we were looking across income level. And this was in a study, a very large population-based study called the REGARD study. And so hopefully what you can appreciate is we're looking at people at the lowest level of income of less than $20,000 a year for the whole household, up to more than $75,000 per year. And you can see there's this gradient where the people who earn the least have the highest rates of having this marker of chronic kidney disease. What I hope you can see this gradient sort of going down. What I hope you can appreciate is that gradient is steeper for the black participants in the study, right? And so much so that when we went on to kind of account for other factors, diabetes, rates of hypertension, age, gender, and so forth, we found that there was a stronger association between level of income and this marker of kidney disease among the black participants than there were among the white participants. Now, I give this sort of talk in a lot of audiences, and people say, oh, are you saying that income doesn't matter for whites? That is not at all what I'm saying. I'm saying that it seems, and I'll show several examples of this, that income level and other metrics of socioeconomic status seem to play a greater role in risk of kidney disease among minority populations than it does among whites. So as another example, we did a similar study in Baltimore, where I'm based, again looking at higher versus lower socioeconomic status, and again found a stronger association between low socioeconomic status and kidney disease among the black participants. Okay, so this was somewhat shown, a similar slide was shown earlier, but the basic message is that when we look at earlier stages of kidney disease, so stages 1 to 4 here, stage 5 and beyond being typically where we're going to begin to classify someone as having end-stage renal disease. So what you can see is that these bars, we're looking at non-Hispanic whites, non-Hispanic blacks, and then Mexican Americans, and then everyone together. I want you to focus on these first two bars and note that they're the same height, right? And so in general, and this has been documented time and time again, when we look at earlier stage chronic kidney disease, the rates are actually pretty similar between non-Hispanic blacks or African Americans, whichever term you use, as compared to whites. The rates are pretty similar. But when we begin to think about progression of that disease, it's that the progression of kidney disease or decline in kidney function is faster among racial and ethnic minorities than it is among whites. And so this study, this is from the multi-ethnic study of atherosclerosis. What they were looking at is they looked at participants in the study who began with a glomerular filtration rate that was greater than 90, which is very much normal, or those who began with a GFR that was between 60 and 90, and they looked over time. They followed these participants. I think it was 5 years of follow-up here, and they were looking at, who was losing kidney function faster. And essentially, what they found was that blacks and Hispanics lost their function faster, even at this stage of pretty good kidney level of kidney function. And when we looked at the group that already had, a sort of slightly reduced function, although still in what we would consider normal, that again, blacks and Hispanics had a faster rate of progression. So what we're dealing with is more of an issue of progression of disease. So I want to summarize these pre-ESRD disparities that I've covered to say that independent of diabetes and other clinical risk factors, racial and ethnic minorities and individuals with lower socioeconomic status have greater risk of albuminuria, so that's the protein in the urine, and also a greater risk of progressive kidney function decline. And socioeconomic factors may underlie these racial disparities. So when I turn to disparities in ESRD and dialysis, which have been touched on a little bit. And I won't go through the nitty-gritty of this slide, but just to say that this is very similar to what we looked at a moment ago when we were looking at rates of albuminuria, or the protein in the urine. To say that when we looked at groups of, here, the team that looked at this, when they divided up African American men and women compared to white men and women who had, had diabetes, didn't have diabetes, had hypertension, didn't have it, had the combination, didn't have the combination. No matter how they sliced the population, the rates of developing end-stage renal disease were higher among African Americans. So it is not explained by rates of diabetes or hypertension, okay? So with respect to income level, this was a study now from 22 years ago that was it was the earliest study really to look at this differential association between income level and race, and then risk of developing end-stage renal disease. the major take-home message here, again, is that this steep sort of association between income level and the chances of developing kidney failure, it's much steeper among the black patients, which they're represented in the group that has the boxes there as the on the bar. And so this has been looked at more recently by a group that's based in Atlanta. And what they were looking at here was they were looking at neighborhood levels of poverty. So instead of kind of knowing how much money an individual earned in an individual family was earning, they were looking at rates of the sort of the proportion of individuals living in a community, living in a neighborhood, who had an annual household income that was at or below the federal poverty level. So the federal poverty level, particularly around the time of this study, was about $25,000 for a family of 4. So if a family hits that or beneath, they would be considered to be living in poverty. So they were looking here at, in the neighborhood, there was about 5% or less who lived in poverty, all the way up to 25% or more who lived in poverty in the neighborhood. Major message from this is that that's where you see the greatest difference between the blacks and the whites in terms of rates of kidney failure. Okay, is when we're in communities that have very high rates of poverty. And so, kind of to hammer this point home a little bit more, we were really interested in, well, is it just, where people live, or is it also kind of what's surrounding where they live? So meaning, is it, we sort of hypothesize that if a person is living in a community that is that's poor, that's impoverished, but is surrounded by wealthier communities, could some of the resources in those wealthier communities maybe filter into that poor community, making that person's risk, in this case of kidney disease, a little bit less than maybe someone who lives in a community that's impoverished, that's surrounded by other impoverished communities. And so we did, find a suggestion of that, meaning that, there's sort of a trend here where those that lived in, communities, these sort of high outliers, those that lived in the communities that had, tons of other communities surrounding them that were also impoverished, did have slightly higher rates of developing kidney failure. I want to turn a bit, this point was made earlier, I want to turn a bit to this issue of late referrals. Now, Dr. Swanson was talking about referral to transplantation. Here I'm speaking about referral to see a nephrologist, which has been mentioned a bit. So in general, blacks are actually more likely to receive late referrals. They are referred later in the course of kidney disease to see a nephrologist than are whites. That's the basic message of this slide. Now, why does it matter? Well, late referrals to a nephrologist actually result in worse outcomes, and particularly among blacks, right? So it's bad for everyone. So if you look, so for whites, those that were referred late had a 50% greater risk of dying. This is after they had started dialysis in this case. But for blacks, if they were referred late, they had an almost 7 times greater risk of dying. So that's a big issue. And then this is a recent study that I found very noteworthy in that essentially, so in communities in America, there are, so in general, let me actually just sort of trace through the far right-hand side of the slide here. What it's reflecting there is the proportion of the U.S. population that lives in poverty. So they looked at 1995 to 2004, and there was 10.9% of the U.S. population living in neighborhoods or communities that had high levels of poverty. And then in more recent years, it's 12.5%. So that number has increased slightly. But when we look at the population that is beginning dialysis, right, in that older time period, 20 years ago, 27.5% or so came from communities that were impoverished. But now 34% are coming from communities that are impoverished. So it sort of gets at, some of the challenges, many of the challenges that our patient population is facing today. And so those of you who are nephrologists in the room, we should have like a secret handshake or something. Okay, so or a wave. So for the nephrologists in the room, I'm sure are likely aware that for years, the data has suggested or shown us that African Americans who are treated with dialysis have better survival than white patients, right? So meaning you took all African American patients in the United States, you took all white patients in the United States, and you follow them over time. Several studies have shown us that African Americans live longer. So that notion has been challenged recently in a couple of studies. I'm showing one of them that I was fortunate to be involved in, and letting us know that survival advantage, if you will, is not true for every age group. So for older populations, that's true. So for people over 50, it appears that African American patients on dialysis do tend to survive longer than white patients who are on dialysis. Now, our transplant colleagues will say that it's sort of confounded by the lower rates of transplantation among African Americans, and so people who would have otherwise have been transplanted if they were white are staying on dialysis, and so forth. We can have that conversation later today if you'd like. But when we do look at the younger population, people who are under 50, what we see is that for young patients, African Americans actually have poorer survival than do white patients. And what we found in this study is that seems to be largely accounted for by differences in socioeconomic status. So for the group, you see that orange line there, for the lower socioeconomic status Black patients, and again, they're young dialysis patients, they had a particularly poor survival compared to the other groups. So that finding of this better survival is complex and should not lead anyone to think that transplantation is not the best treatment for patients with end-stage kidney disease, because it trumps all of what I'm showing you here in terms of rates of mortality. Transplantation is better than any of these dialysis findings. So to summarize this section, so compared to whites, racial and ethnic minorities are more likely to develop end-stage renal disease. They're referred later to nephrology, generally more likely to survive on dialysis, although that's not true among younger adults. And then finally, these disparities may be strongly influenced by socioeconomic factors. Turning to transplant. I apologize, this slide got moved a bit. So it's been known for a while now that when we compare, here we're comparing again African Americans to whites, there are fairly equal rates of patients who have advanced kidney disease and are of either race. There are pretty equal rates of them being medically suitable and interested in going on to get a transplant. This is in green, those are whites, and in red, it's African Americans. But then as we move through the steps of the transplant process, particularly when we get now to the wait list and the actual receipt of transplantation, that's when we start to see these disparities, okay, in terms of where whites are going to be more likely, African Americans less likely. So why is that? I found this study very interesting recently that was looking at, they were looking at rates of living kidney donation across race and also across level of household income. And whereas it's been known for a while now that certainly rates of living kidney donation are lower among African Americans for a number of complex reasons, in this study, what they found is that at the highest levels, when they took people who kind of had a pretty high income at the highest level, they're at quartile 5, that actually the Black living donors were more likely to donate. And so the message, more likely than whites. And so the message from this study was that, again, financial sort of pressures may be the real barrier to African Americans who may want to donate a kidney. That it's less about cultural this and religious that and all those sort of things that you all have heard about, and more about pocketbook issues. Like it's concern about whether they're going to be able to afford to take time off from work and so forth. And so I think there's a real opportunity here. And so, again, as I mentioned, transplantation, absolutely the best treatment, regardless of a patient's race. And what in our group, we recently looked at, this is a paper published in JASN for the nephrologists in the room. What we looked at recently was rates of deceased donor kidneys and their survival over time. And what we basically found was that the rates of survival have improved for all patients, with greater kind of improvements for Black patients than we've seen for white patients even, and the disparities in outcomes as far as the survival of these grafts are actually narrowing in recent years, which is very encouraging. So summary again for this section, so compared to whites, racial and ethnic minorities are equally as interested in being transplanted, but are less likely to complete the steps towards transplantation and less likely to receive living donor transplants. Disparities in the receipt of live donors may, again, be strongly influenced by socioeconomic factors, and racial disparities following transplant are actually narrowing. Okay, so why? So this is a large, and I'm not going through this whole thing, don't worry. This is a large conceptual framework for thinking about social determinants of these disadvantages in kidney disease. And I'll just mention the three sort of big baskets, everything from residential issues and residential segregation and all the factors that kind of flow from that, discrimination and kind of the stress that it can play in individual patients in that situation, and then insurance status and the role that it plays. And these can all ultimately lead to kidney disease, progression of kidney disease, and then ultimately mortality. I am going to focus on one of these, and that's poor nutrition. So this is an area that I spend actually most of my time working on. And so big kind of message is that healthy foods are actually in limited supply in some communities. That's not a shocker to anyone in this room, right? No one's surprised by that. Okay. So some of you may be familiar with these terms that are used when we think about healthy food availability. So one is a food desert. This is going to be an area that has little or no access to a large grocery store that offers fresh and affordable foods. A food swamp, maybe a term you're less familiar with, is going to be an area that has an overabundance of high energy foods that kind of overwhelm the healthy options. So there's food there, it's just not healthy food. And then finally, food insecurity, and this is the limited or uncertain ability to acquire nutritionally adequate foods in safe and socially acceptable ways, right? So basically people who are not able to afford food. So this is a map of Baltimore City and Baltimore County, which is where I work. So the box there is Baltimore City, and then the area surrounding it is Baltimore County. And this was a study that looked at the presence of healthy foods in the stores that are in these neighborhoods. And they were looking at also whether these were neighborhoods that were predominantly white in terms of the inhabitants of the neighborhood versus predominantly Black. And that's represented in the predominantly Black neighborhoods are in white, the predominantly white neighborhoods are in shaded gray. The amount of healthy food is indicated by the size of those green circles, okay? So what you can hopefully appreciate is that the large green circles primarily overlay the gray shaded areas. I'll give you a second to take that in. And in fact, the authors of this study found that indeed the minority, predominantly minority or low-income communities were those that had the least amounts of these healthy foods, and they used a validated index for this. Were less likely to have these healthy foods in those stores. So as it turns out, healthy foods are also more expensive than unhealthy foods. How many disagree with this statement?
100% accurate.
You think it's accurate?
Yes, it is.
Okay. Anyone disagree? Anyone think you think healthy foods are actually less expensive? Okay, all right. You know, it's interesting, and this, I don't want to digress too much, but in the 80s, certainly the case was that healthier foods probably were less expensive, but there's been this real boom in terms of processed foods to where they used to be expensive, but now they've become cheap. And so some of these unhealthier foods are now cheaper. And so as it turns out, this is a true statement. It's based on sorry, I don't have the reference there at the bottom, but it's based on a large meta-analysis, so a study that combined a bunch of other studies that had been done, where they were looking at 27 studies that came from 10 countries around the world, mostly high-income countries. And indeed, what they found was that comparing kind of extremes of different types of dietary patterns, healthy diets cost on average $1.48 a day more than unhealthy diets. And so we were interested in this issue of food insecurity, again, so inability to afford these healthy foods, and how it might relate to kidney disease. Bless you. Bless you. So we used data, sort of nationally based data, and found that around 25% of particularly the lower income individuals in this data set had food insecurity. And what we did was then we went to and we looked to see, was food insecurity associated with kidney disease? And what I want to just highlight here, without going into all the details of this figure, is that what we found was that food insecurity was associated with kidney disease, but only among people who had either diabetes or hypertension, which diabetes is our leading cause of kidney disease, our leading cause of end-stage renal disease. Hypertension attributed kidney disease, which I'll get back to why I'm saying attributed, is our second leading cause, right? So it's an issue for the patients that we're focusing on. This may be an issue. If they've got food insecurity, they may really have some challenges. So we were interested in what people are actually eating in their house. I get groans every time I show this slide. So we wanted to see, so how many of you have heard of the DASH diet? Great, okay, I'm looking to make sure that some of the non-physicians actually raise their hand. So terrific. So the DASH, so this is a DASH diet. This is kind of a photo of what's included in it. It's considered a dietary pattern that's very healthful. It's rich in fruits and vegetables, low-fat dairy foods. It's low in fats and sugars. Those are the kind of components of the DASH diet on the right. So what we wanted to know was how do people who live in poverty versus don't live in poverty, how closely is their diet to being a DASH-like diet, right? And so that the previous slide I showed you, there's an actual score that you can use if a person is meeting all of those targets, then they get a score of 9. Following or being accordant to a DASH-like diet or adherent to a DASH-like diet is if you have a score of 4.5 or better. You can even get a half point. If you're sort of almost at the target for those different nutrients, you can get a half of a point. So let's look at our population. Now this is a Baltimore-based population of individuals. Half of them are African American, half are white. We were focused on poverty. And big message is that almost no one was meeting this adherence target. So only 4.5% of the people living in poverty, 6.1% of the people not living in poverty. If you look at the scores just above that, they were extremely low. And when we looked across the different nutrients, what we found was that there were quite a few differences between the poverty group and the non-poverty. Notably, I think someone's already saying it, there was no difference in sodium between the two groups. And my nutrition colleagues tell me that's because everyone's eating too much sodium, right, regardless, and it's in everything. And so this was really telling. And there's been some, so we went on to look to see how, is that associated with kidney disease? Is how closely a person's following a DASH-like diet associated with kidney disease? And indeed, it was, but it was only associated, in this population anyway, among the people living in poverty, right? So, we were left kind of thinking, well, perhaps if a person lives in poverty and is somehow able to follow a healthful diet, maybe look at that green bar over there, maybe they can really reduce that risk of kidney disease. We've gone on to, sorry, I'll go back here. We've gone on to study a similar type of question in other populations and have found indeed that following a DASH-like diet is associated with lower chances of having your kidney disease get worse over time. And there's sort of several studies that are slowly but surely coming out around this. So I think there is some cause for optimism in terms of thinking about what might be something we could do for patients with respect to diet. How am I on time? I feel like I can speed up if I need. No? Okay, I'll keep going, all right. Okay, so you can cut me off whenever. So one of the things we were interested in is, again, so what's in people's homes? And so we turned to, this is a study that I have worked on. It's the Achieving Blood Pressure Control Together study. Big messages are that it's a study of African American patients who have uncontrolled hypertension. And we're kind of trying to help them to be more actively engaged in their management of their hypertension. And one of the things we did in the study, and I should say that for the clinicians in the room, both the nephrologists and the primary care providers and others, you probably know that the DASH diet has been shown to be very effective at lowering blood pressure, right? It's been also effective. It's been shown to people who follow a DASH-like diet are less likely to develop heart disease. It has benefits for several conditions. The DASH diet has actually, in particular, been shown to be effective for African American patients. So if you don't have to raise your hands, but if you're in the room and you're African American and you have hypertension, you definitely should be on the DASH diet. It's almost better than some medications in terms of lowering blood pressure. And it's not a weight loss diet. It's really a blood pressure control diet. So what we were interested in is among this population of African Americans with uncontrolled hypertension, how many of them had foods in their home that would allow them to follow a DASH-like diet, right? Sort of a simple thing. So we sent our study team in the course of this study to look and see, what's there. And you see these different food groups. So you'll see that, this is the proportion that had the things in the home. So about 21% didn't have any fresh or frozen vegetables. And about 42% had no fresh or frozen fruits, right? And it sort of goes on from there. And only 14% had all of the food groups in their home that would allow them to be able to follow a DASH-like diet. And not everyone had a full-size refrigerator or oven that would allow them to store or prepare these types of foods. So I should have mentioned, this is a population they're based in it's a clinic population based in Baltimore, a very low-income population. And we found actually that younger age and actually having kidney disease raise the chances that these patients would not have these foods in their home. So the younger people didn't have them. The patients with kidney disease didn't have these things in their home. Okay, so why? So I mentioned that we've talked about a lot of these things about diabetes and hypertension not really explaining these rates of kidney disease, these different rates as far as across races. So many of you may be aware that in the last 5 to 6 years, we've had an exciting discovery in the nephrology world, in that this genetic marker, or this genetic factor, apolipoprotein L1, was found to be associated with developing kidney failure, primarily initially in the initial studies, among African Americans. It was found to be a big risk factor for this. Okay, and this genetic factor is kind of similar to, in a sense, to what we know about sickle cell trait. So most of you maybe know about sickle cell disease. So if you have just the trait, it protects you against malaria. If you have 2 copies of the genetic marker, you get sickle cell disease. Well, in this case, if you have just sort of 1 copy, I'm simplifying it, but if you have just 1 copy, it protects against this trypanosomiasis, which is African sleeping sickness, very bad condition. But if you have 2 copies, it seems to raise your risk of developing kidney disease. And roughly 12% or so of people of African ancestry, I should actually broaden that statement, have this genetic variant. And so in this paper that came out of the New England Journal, they essentially found that people who had 2 of these high-risk variants, it was associated with them having progressive kidney disease. But what I'd like us to think about, particularly today, is that 40% of the people who didn't have these genetic factors, 40% of the people with these genetic factors did not develop kidney failure. You hear what I'm saying? So it's not an absolute. So having these genetic markers does not mean absolutely that a person's going to develop kidney disease. And so it's kind of opened up a lot of questions. And the other thing that was important was even when they compared the African Americans in the study who didn't have this genetic factor to the whites in the study, the African Americans still had higher rates of developing kind of worsening of their kidney disease. So there's sort of something else. So this genetic piece doesn't explain everything. And also the genetic piece by itself isn't enough to give a person kidney failure. It seems like there's something else. There's a second hit. There's another factor. And so there's a number of groups that are working on trying to understand what that is. It's a big, yes, oh good, I'm perfect. So I want to summarize this issue of this potential causes. So as far as social determinants, access to and consumption of healthy foods, may be a cause, access to high-quality health care, chronic psychological stressors are other factors, and then these genetic determinants may play a role as well. And so how? Since we're going to be talking about this for the rest of the day, I want to just think about the solutions that help to end health disparities and broadly to help end to help face some of these challenges that we're facing in terms of kidney disease will certainly be as multifaceted as the causes. I think that we're in a particularly important time as we think about the Affordable Care Act and the fact that now this is a figure that just sort of shows us who the newly insured individuals are, right, and continue to become. So they're less likely to be white, they're less likely to say that they are in good or very good or excellent health, they're more likely to be single, they're less likely to speak English, they're less likely to have had a college degree, and they're also less likely to have full-time employment. So these are going to be populations that are now in the recent years kind of entering our health system who haven't been here in the health system. And we're going to have some real opportunities, I think, to help them have their best health and have their best kidney health. We know from previous work, I'll just quickly go through this, that when we take our patients who develop kidney failure and we compare blacks and whites, and they're starting dialysis, and as was said earlier, they automatically become eligible for Medicare. We know that although in the non-kidney failure population, whites are going to be 3 times as likely as blacks to get access to sort of high-end specialty services like cardiovascular procedures, like cardiac catheterization, for example, right? But when we start the patients on dialysis and they get their Medicare, those disparities go away. And the big thing, it's in this case, it's likely due to Medicare coverage. And so I'm hopeful that we may start to see some elimination of at least some of the health care disparities now with the Affordable Care Act. And so I want to acknowledge certainly my funding sources. I definitely, as Dr. Shahinian did, I want to certainly point you to our CKD surveillance website that's cited there. And I want to end with this slide, and again circle back to what I said earlier, which is again to say that disparities in kidney disease are certainly pervasive. However, they may be surmountable. And I would invite you all, if you're very interested in this topic, we had an issue in the Advances in Chronic Kidney Disease journal that is focused on this topic, and this is the cover from it.